Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Prasad Katta. Dr. Katta graduated from the University of Gulbarga, India. He completed his residency in medicine in Great Britain and obtained the degree of Member of Royal College of Physicians. He conducted his residency in internal medicine at the University of Medicine and Dentistry of New Jersey in 2002 and a fellowship in endocrinology from Charles R. Drew University at UCLA in 2004. Dr. Katta is board certified in internal medicine and endocrinology. His interests include diabetes, thyroid, and osteoporosis.
I'm sure some of you may be surprised with the title of the talk, Type 1.5 diabetes. Some of us even call it Type 3 diabetes. So there are various, and as you see on the title slide, it's also called as Lada, L-A-D-A, and that stands for latent autoimmune diabetes in the adult. So latent autoimmune, it also you can say as late autoimmune. Later on in life they get it, autoimmune diabetes in the adults. So what are you going to learn in this talk? One is, how do you define as latent autoimmune diabetes of the adult, or LADA? And what are the characteristics of the patients who have this? Means how do they look, and how can they behave, how are their sugars, so on and so forth. And also we need to know how to differentiate it from type 1 and type 2. You know type 2. Type 2 is the most common form of diabetes. About 90 to 95% of the patients have type 2 diabetes. This comes in usually later on in life, but nowadays even children or kids as young as 7, 8, 5 years old do get type 2 diabetes because of the reason of the weight, obesity, overweight, being so on and so forth, on the diet, exercise part of it. Type 1 is more common in young children, but again can occur at any time pretty much. Understanding the criteria for LADA, who do we define as patients who have LADA? So again, as I said, the term LADA was initially, I think, was coined in the 80s, 1980s, but it sort of caught on over the last, I would say, last 1 to 2 decades. We are using it more. So, and also familiarize the diagnostic test for LADA. Means it's not that different. It's pretty similar to how we diagnose type 1, but I still want people here and also who see the talk later on to understand that how do we diagnose these kinds of patients, and also recognize the patients who should have this antibody testing, because sometimes you may go to your doctor, you're on medications, you're all on the right medications, but it's not making sense. Your sugars are still high, patient is saying, I'm doing all my diet, exercise part of it too, I'm taking my medications, then you will have to do some antibody testing to see where the patient belongs. And also understand the management of such patients, type 1.5 or the LADA patients. So what is type 1 diabetes? We know that in type 1 diabetes, pretty much the patients don't have any insulin at all. That means the beta cells which produce insulin from the pancreas is completely destroyed, and that leads to an absolute insulin deficiency. So they don't have any insulin. So that's why even if they eat like maybe half a slice of bread, her sugars can go to 250, 300s when they don't have that. So that's the thing in type 1 diabetes. It's diagnosed in childhood or young adulthood, usually within the first decade, second, third decade. That's the time when you get type 1 diabetes most of the time. Less than 35 years, as it says there, and considered to have autoimmune disease. So what do you mean by autoimmune disease? Our own immune cells, defense cells in our body attacks the pancreas. So, and that destroys the cells which produce insulin, or the beta cells which produce insulin, and that leads to type 1 diabetes. And it's very dramatic. Pretty soon what will happen is, like, let's say you're okay, in the next few days, in a couple of weeks, you're really feeling bad, you don't know what happened, you're sort of drinking a lot of water, urinating, losing weight. Within 2 to 3 weeks you'll develop these symptoms, and one day a patient can get admitted to the hospital and the sugars can be 400, 500, and that's how you diagnose like type 1 diabetes. Most of the time that's the way it's diagnosed. Or they may see the doctor and the sugars are very high. So type 2 diabetes, we know that, and a lot of patients, as I said, 95% of the patients have type 2 diabetes. This is a more slow progression, slow onset. You may not have any symptoms at all. Most of the patients with type 2 diabetes may not have any symptoms. Only if the sugars go beyond 200, 250, 300, then they may start having some symptoms. It could be just tiredness, fatigue. Again, the other symptoms which I said, increased urination, drinking water, also losing weight, and also you may be eating more too. Those all are the symptoms for type 2 diabetes in later stages. It is characterized, main characteristic or the point of type 2 diabetes is its insulin resistance. What that means is basically your body is producing insulin, but how you're utilizing the insulin, the body is not utilizing it properly. So there's a lot of resistance for the body to use the insulin you're producing. And also to some extent there is some relative insulin deficiency, means because the body is not able to produce enough insulin, and also because of the resistance, the sugars go up. And this is usually not autoimmune, it's more because of genetic factors, because of weight gain, because of lack of exercise, so on and so forth. So what about type 1.5 diabetes or Lada? Okay, as I said, it's also called type 3 diabetes. So many different terminologies are there, but we'll stick to type 1.5 or Lada here. So this, I've just wanted to show a figure, the two leaves sort of intersecting. Again, don't think that there are that many patients with type 1.5 diabetes. It may not be that many patients. Usually we say anywhere from 5 to 20% of patients who have type 2 diabetes can develop Lada at some point of time in their life, but that's the intersection. The green leaf is the type 2 diabetes and the brown one is the type 1, and the sort of the yellow depiction in between is the Lada patients. So what was the history of Lada? As I said, in the 1980s there was a study which was the main author was Group et al, and he reported two subgroups of type 2 diabetic patients who, despite having, they had antibodies. Antibodies are usually present in only type 1 patients, not in type 2 patients. They had antibodies, but they still did not need insulin in these patients. They were behaving like a type 2 patient. So they showed that their pancreas could produce insulin. So the type of diabetes in these patients were referred as latent type 1 diabetes. So they thought that they'll develop type 1 diabetes later because of the antibodies, because at this point of time they did not need insulin. So this was clearly different from the type 1 diabetes where insulin is needed from the get-go. So it's absolutely needed from the get-go. So in 1993, another group of scientists, Toomey et al. And Zimet et al. In 1994, they launched this term or eponym called Lada, and for slowly progression of autoimmune diabetes, initially managed with diet and exercise. Since they don't need insulin initially itself, they can be managed with diet and exercise very well actually in these patients. They don't need insulin at all and they can be managed with diet and exercise. And even some oral medications, metformin, other kind of sulfonylurea medications do work in them because the pancreas still has the ability to produce insulin. Later on in life, they start requiring insulin, so that's the reason why we call it Lada. So again, I wanted to show different types of diabetes and take you through this slide. So initially, if you look at the first in the 1970s, the juvenile diabetes, it was called juvenile diabetes and adult onset diabetes based on the age. So juvenile was like type 1 diabetes and adult onset was type 2 diabetes. Later on, we called it insulin dependent or insulin independent or non-insulin dependent. That's what we called it. So insulin dependent was again type 1 diabetes, and insulin independent or non-insulin dependent was type 2 diabetes. But that was not correct also, because a lot of type 2 diabetes need insulin later on in life. That doesn't make them type 1 diabetes. So later on we said type 1 and type 2 diabetes in the year 2000, and that's the reason why we all, from then onwards, we have used type 1 and type 2. And more recently we have had this Lada also come into the picture, so it's in between. The side on the left where you are sitting is the immune mediated diabetes. It is your immunity acting against your own cells which produce insulin, and that's type 1 diabetes. And the one on the right is the insulin resistance, insulin secretion, and chronic inflammation, and this is the type 2 diabetes, and somewhere in the middle is Lada. Okay, so the latent autoimmune diabetes in the adult, Lada, it's late onset autoimmune diabetes of the adulthood. Slow onset type 1 diabetes, it's also called slow onset type 1 diabetes because initially itself they don't need insulin. And it's oftenly mistaken for type 2 diabetes because on the age and the time of diagnosis. Because the reason that is they may not need insulin and they think, okay, age 35 years, age 40 years, they're not needing insulin, it's probably type 2. But actually it is Lada. The difference between type 1.5 and type 1 diabetes, it develops both in adults and it can also develop in children in type 1 diabetes. And progresses to need insulin in about 6 years. Okay, usually initially 6 months, 1 year, 2 years, you may not need any insulin at all, and you can and will be able to control the patient with diet and exercise and medications. If you look at this slide, Lada is often diagnosed as type 2. That's very important because that's the way they behave, and later on they can change where they start needing insulin. So this is another cartoon figure I wanted to show to you. The one on the right is type 1, okay, where they show the kid, and it's absolute insulin deficiency. One on the left is type 2, where it's relative insulin deficiency, more importance to insulin resistance, and somewhere in the middle is Lada. All of these lead to high glucoses, that is hyperglycemia. This is the whole diabetes spectrum. So that's what we call it, type 1, type 2 on the other side, and Lada in the middle. So this basically shows how your insulin producing capacity in a patient can deteriorate. So the y-axis is the insulin producing capacity, starting from 10, 20, 30, goes up to 100, and the x-axis is the age. Age at the diagnosis is here in the x-axis, and the y-axis is on the other side. So if you look at it, if there is a rapid decline from 100 down here in childhood, we pretty much think, yes, that's type 1 diabetes. This can also occur in Lada to some extent. And there can be a stair-step decline, little initially, and then come down. Most of the times what happens is there'll be a zigzag decline a little bit. Ultimately, they lead to Lada. So at age 30 years or something like that, then they lead to Lada. So that's what happens. Until they reach that breaking point, they can be controlled with diet and exercise. That's the most important thing. Later on, they'll need insulin for sure. But in these patients who are behaving like type 1, they may be needing insulin even earlier. So as I said, it can take up to 6 years for them needing insulin. That's not always the case. It can be even earlier. But that is the reason that once you diagnose a patient has antibody positive, I'll come to the antibodies a little bit later, that you have to follow them and make sure they come back, because and let them know that more than likely they will have the need for insulin. You don't know when, you can't predict it, so on and so forth. This is a tabular form I wanted to show you. So type 1 diabetes, typical age of onset, youth or adult. In Lada, it's usually adult. And in type 2 diabetes, it can be teen or adult, because as I said, even young kids also can get it. Progression to insulin dependence. In type 1 diabetes, it's usually days to weeks. But if you look in Lada, it is months to years. And in type 2, it's very slow, it's in years. Now, presence of autoantibodies, both in type 1 diabetes and also in Lada, it is positive. But in type 2 diabetes, there is no antibodies. That's for sure. Insulin dependence, again, all diagnoses at the diagnosis itself, they'll need to start insulin, and all of them will need to take insulin in type 1 diabetes. But if you look in Lada, it's within 6 years, but it can happen at any point of time. And then type 2 diabetes, it's over time if at all. It won't happen all the time. Sometimes they may not need insulin. So insulin resistance here, there is no insulin resistance. In type 1 diabetes, there's no insulin resistance. In Lada, there is some insulin resistance. And if you see in type 2 diabetes, yes, that's one of the most important factors. You have insulin resistance for sure. Why is Lada significant? Again, as I said, approximately 5 to 20% of people diagnosed with type 2 DM are found to have Lada. And the reason because is initially they can still produce some amounts of insulin, so you can treat them with diet and exercise. Occurs in people over the age of 30 years without severe symptom. Medications designed to reduce insulin resistance do not work, as people with Lada have little or no insulin resistance at all. So you can use medications like glipizide, glimepiride, glyburide maybe, but the metformin or the pioglitazone, Actos, those may not work because those are the ones which actually control your insulin resistance to some extent, and those may not work. People with Lada progress more rapidly to insulin treatment. Again, I've told this already 3 or 4 times, but I'll mention it again. People with Lada don't require insulin for the first 3 to 6 months following the diagnosis, but up to 80% of the patients will require insulin in the next 5 years. So criteria for diagnosing Lada, adult onset of age 30 years or older. You have to distinguish between Lada and type 1 DM itself. So criteria for Lada is positive at least for one of the autoantibodies found in type 1 diabetes. That distinguishes Lada from type 2 because type 2 diabetes, they don't have any antibodies. The third point is free from insulin treatment for the first 6 months after diagnosis. So what are the antibodies? This is anti-GAD antibody. That's the most important antibody we check in patients if we think they have this condition. So what does GAD stands for? Means glutamic acid decarboxylase. Basically, it's an enzyme. It helps in the chemical reactions. So what does it do? It is actually present in the cytoplasm, which is in a cell. Part of the cell is called cytoplasm. And in the beta cells, which produce insulin, it's present in the cytoplasm. And it helps conversion this amino acid, glutamic acid, to GABA. That's what it does. So what does GABA do? GABA is involved in the insulin release of insulin from the secretory granules of the beta cells. So that's what it helps to produce insulin. So what is your body doing is your body is producing antibodies against this. So what does it do in the patient? So insulin won't be secreted then. So if you have more of these antibodies, insulin won't be secreted, and that's the reason they need insulin later on in life. So the diagnosis we usually do most commonly, I would say we do this, the GAD antibody test, most common method. We also sometimes do this. This is an indirect measure of secreting insulin. It's called a C-peptide test. It's a measure of endogenous, which is how much insulin we are producing ourselves. If it is positive, then you should be okay. You may not need insulin, or you may need very little insulin, or you may be able to be controlled with oral medications. So we also do islet cell antibodies. That also is fairly common, and we do it in patients who we think have Lada. So I wanted to show this. We call it scatter diagrams. So we take each individual circle is a patient. This is patients who did not have the antibody test positive. That means they were antibody test negative. On this side is the antibody test was positive. That is the GAD antibodies. That's what I spoke to you about now, right? That's the antibodies. So now you look at it. So the age at diagnosis is on the y-axis here, and the time to diagnosis to the need of insulin is on the x-axis here. So if you look at in the patients who had anti-GAD negative, they took a longer time to need insulin. So it went from a lot of patients needed, yes, at 0 years itself, but if you look at it, a lot more patients went on to up till 30 years and they still didn't need insulin. So when you look at GAD antibody positive, majority of them needed insulin straight away. Very few patients here later on in life they needed insulin. So that is the difference between if you have the GAD antibody positive in these patients, they'll need insulin more quickly, and you will have to monitor them probably more closely and also explain to them, educate to them that they may need insulin more quickly than the patients who are negative. I want to show you a small video here.
In Health Check at 5, a type of diabetes you might not even know exists. We've all heard of type 1 and type 2. Type 1, when the body isn't producing insulin, it's typically diagnosed before the age of 20. Type 2, usually diagnosed later in life when the cells don't respond properly to insulin or there isn't enough insulin being produced. But a 35-year-old man actually fell in between. News Channel 4's Jolene Cheney has the story.
This all came to light when a seemingly healthy man started having symptoms he'd never had before. So he scheduled an appointment with his doctor and eventually got a diagnosis that most of us have never heard of before.
I started researching some things online, and everything was like pointing to diabetes, and I was like, well, that can't be right because, I don't fit the mold.
Nathan Mobley was slender, active, had a healthy diet, but he was always thirsty and couldn't stay awake.
I felt like I was kind of sluggish at work. It was actually kind of hard to pay attention at times, but just very tired. I never would take naps and stuff on the weekends, but I would because I felt just completely exhausted.
Type 1.5 diabetes is also known as Lada. It stands for latent autoimmune diabetes in adults. And people who have it show both signs of type 1 and type 2, but they're often misdiagnosed as type 2 diabetes. At first, Mobley's doctor thought he had type 2, then type 1.
It may be that Lada works in this very same way, but when the immune system is triggered, it's slow and deliberate, but sustained, whereas with usual type 1 diabetes, it's very dramatic and very marked.
Then the diagnosis from the Harold Ham Diabetes Center at OU, type 1.5. The body's immune system actually destroys or damages the insulin-producing cells.
But it does this in a way that's on a timetable that's much more drawn out and more gradual than usual type 1 diabetes.
Mobley weighed and lost several pounds, battling this unusual disease with exercise, nutrition, and oral medication. Jolene Cheney, News Channel 4.
In the early stages of Lada, patients typically do not need insulin but require it in later years.
Okay, so that's what we pretty much talked about, that it is sort of slow in onset, but once you start feeling it, you'll really need to know, okay, that you will need to take medications, probably maybe insulin, depending upon the patient. And as you saw in the video, that this patient had a lot of symptoms of diabetes, definitely. So he was behaving like he was slender, he was lean, so type 1 diabetes goes in favor of that, but also with respect to he had lost weight and his sugars were high, but he was treated with oral medication, so it sort of goes in favor of type 2 diabetes too. So how do the prevention of Lada means there's not much you can do, because with respect to preventing your immune system, it's very difficult how your immune system behaves to one insult or the other, or a cold or a cough. Anything can trigger these kinds of immune systems to attack your pancreas or form antibodies against yourself. So the only thing you can do is probably identify a Lada patient by using the anti-GAD assay or the antibody. It's a high proportion of them are likely to be positive in these types of patients, 70 to 80%. Their identification again is very important, because initially you can treat them with oral medications because the pancreas ability to produce insulin is still preserved, and later on you can use insulin and let the patients be educated about that they may need insulin later on. The other thing is probably reducing the long-term risk of complications of the eyes, kidneys, and also the nerves and so on and so forth, and to some extent the major arteries, which include the prevention of stroke and heart attacks too. So who should be considered for antibody testing? Age onset less than 50 years, acute symptoms. Someone has acute symptoms of diabetes, yes, definitely antibodies should be tested in them. Someone who is diabetic and their body mass index, where their weight is, they're not overweight or obese, less than 25 kilograms per meter squared. if there is a personal or family history of autoimmune disease with respect to the family history, and also, as I said, low C-peptide levels in the body, means you don't check C-peptide that often, because the reason is you always have to check the C-peptide in correlation to their blood sugar. If you just check a C-peptide in someone's blood sugar is 250 or 300, that itself can lower the C-peptide, because we call this as glucotoxicity. So what is happening is the body has so much elevated blood sugars that it decreases or it actually impairs the pancreas to produce insulin. So because C-peptide is a measure of how much insulin you produce in the body, the C-peptide levels will also be low. So always C-peptide levels need to be checked when you're checking your blood sugars, and usually we want your blood sugars to be less than 150 or something like that. That's when you want to check the C-peptide. So how do we manage? Again, at the time of diagnosis, you may not need insulin. It can definitely be managed with diet and exercise, or if you need insulin, you may need it for a very short time, and then can be managed with diet, exercise, and oral medications. Due to the destructions of beta cells, we saw the curves that it may take some time for the beta cells to get destroyed, and they become more and more insulin dependent. As they become more insulin dependent, you'll need insulin. That is different to when you compare to the classic type 2 diabetes. But because in classic type 2 diabetes, it may take a number of years for you to need insulin. But this it can be anywhere from months to years. And they do need, once you develop the need for insulin, you will definitely need more than one type of insulin. You probably need two types of insulin, and it may be more than 3 to 4 shots a day. So that's what, they basically behave like a type 1 diabetes. So these are some of the references.
Well, thank you, Dr. Katta. We appreciate you coming out tonight and doing this talk for us. Thank you all for coming out. We appreciate it.